Wrong,
False.
ma'am.
Yes,
False, ma'am.
yes, that's perfectly right. Uh, Again, we have yet another false because it depends on the tissues. It does not depend on the external size of the breast as such. It could be, they are different tissues than the fatty tissues. So whether the breasts are like, whether it's a size 30, 32, or whether it's a 42, the capacity or the ability to produce milk, there's a different glandular tissue that's required here. So no, not on the external size of the breasts. And the last one. What do you think about this? This is a little tricky-ish. No one?
Ma'am, it depends on the condition of the baby. If baby is having any disease or he or she is having any problem, so we can see or we can take physician's order before giving the breastfeed if baby is in sleep,
Correct.
and otherwise I we can give.
You are right. You are completely right. Until the baby has regained the birth weight, it is necessary to keep nursing the baby. Babies lose weight for a variety of reasons. We've seen this much more often lately because C-sections have increased. IV fluids have been administered quite often, and that actually inflates a baby weight. And so it's not really losing weight, it's more about just balancing it out. But yes, most definitely, like you said, if they have any pre-existing conditions, yes, for sure, and definitely until they've regained their birth weight, they have to be nursed every 1.5 to 2 hours. So yes, I mean, after that, yes, you can go to feeding on demand, but it is important to, if not completely wake up, there are ways of doing it. There's something called dream feeding, which can also be practiced. But the baby needs to be nursed for two reasons. One is baby needing milk on the regular, and the mother needing to constantly remove milk so that there's more that's created. So great. Thank you so much for your little quiz interaction. Let's go down to the basics of breastfeeding. I'm sure everyone, most of you are definitely, but very likely everyone knows this, but this is exactly how a little newborn progresses in the first month of its life. So on day one, their size of the stomach is 5 to 7 ml. That's it. It does not need a 30 ml feed of formula. The baby does not need flowing milk coming from the mother. It's tiny, super duper tiny. Hence the question on the crying, and hence the question on the other non-nutritive needs of the baby. So as you can see, the progression, it does progress, obviously, but then the progression is very gradual. Ultimately, at the end of a month as well, the size is not more than like 150 ml. It's just about the size of an egg. So it's very important to keep this in mind, because especially the day one capacity is something that most mothers or their support structure does not really know of. And there's a lot of things that could go wrong on that first day. So golden hour, golden hour and colostrum. So this is extremely, extremely important. This actually can make or break a breastfeeding relationship, in my opinion. The first hour after birth, whether this birth is a C-section or whether it is a vaginal birth, the first hour after birth is called the golden hour, because that's when you give the liquid gold. That's when ideally breastfeeding needs to be initiated as soon as possible. Even if the mother is, say, under anesthesia, the support system, nurses, I mean, the most vital support structure in that first few days of establishing breastfeeding, can always support the baby, can always lead to the baby crawl. The baby crawl is, as you can see, it is basically uninterrupted skin to skin with the newborn at the earliest. Baths can be delayed. There is no need to immediately bathe the baby. If the baby is active and the baby is showing a good overall APGAR score and everything, then it just needs to go straight to the mother's chest. Skin to skin can work wonders, absolutely. It can literally make or break that relationship, like I said. So this is the golden hour, and this is a breast fall. This is a very beautiful photo of breast fall. What is colostrum? Colostrum is, it is amazing. It is literally what they call liquid gold. It is very, very little because, as we just saw, the infant also needs very little. The capacity is barely 5 to 10 ml, 5 to 7 ml on the first day. And the colostrum, even if it's a little bit, is all that they need. It's just that and the mother's touch and the mother holding them. Kangaroo care, skin to skin. That is what is vital on that first day because this is super concentrated. It's got extremely dense nutrients, proteins, and it is low fat. So it can just be absorbed. And most importantly, it is known as the first vaccine. The reason it is known as the first vaccine is because it is filled with components that can boost and that can actually set up the newborn's immune system. So it is very, very important. There are certain cultures that discard the first milk, and that is just not a right thing to do at all. It is very, very, very important that the infant gets this colostrum, and it is all that it needs. It does not, there is no behti Ganga, like, that needs to happen on that first day. That 5 ml, 10 ml colostrum, that's it, that's enough. And the mother, even if the mother is not fully conscious for whatever reason, she's gone under anesthesia, she's still under it, the infant can always be close to the mother because skin to skin can also happen subconsciously. So that needs to be established. The next basic of breastfeeding is what we know is usually known as attachment, but in technical terms, we call it latch. Latching is very vital. Latching is a lot of breastfeeding problems, which I will discuss later, actually stem from here. If this does not, so yes, of course, breast crawl, golden hour, colostrum, these are all situations, these are ideals. But this is essential. This is absolutely essential because this also determines whether the mother will be able to breastfeed. This is something which can lead to a lot of complications if it is not done correctly. The attachment, very unlike, and the problem is we are so accustomed to seeing bottles and like, breast does not work like a straw, basically. Like, you don't take one second. Let me just get say hi to my little crew. This is my little helper. Uh, I'm just going to be showing you a little bit of a latch. So as it is very evident in the infographic here as well, but just to make it more visible in person, firstly, hold baby at a 45-degree angle, not flat, not completely flat. The baby needs to be elevated and it needs to be in a comfortable position. Flat is fine, but it makes it a little difficult to latch. So, I mean, as long as the mother is okay, and more importantly, actually, the baby should not be like this. The baby should be turned in. The baby should be facing the mother. It should be tummy to tummy, basically. Yeah, like this. So no matter what position we use, we will talk about positions. The baby needs to be facing inward. And the breast doesn't go in directly. The breast does not enter the mouth directly. You always tilt the nipple towards the palate. So you bring it down baby's nose, and they have all the reflexes. They have the moro, they have the rooting, they have the sucking, they have all their reflexes in place right since the second, third trimester. So you do not need to worry whether baby will know. Baby will know. It does not go in straight because that will be a very, very shallow latch. This is how it goes. As it's shown in the infographic that you can see on the screen, you tilt it upwards, just stroke baby's upper lip, and the baby will open their mouth wide. It's a reflex. When they open wide, it goes in like this. You have to take more of the lower part. The lower part of the breast needs to go into the baby's mouth and not straight. So like this, that will ensure a nice deep latch. And also the nose then is far away. The nose is away. You don't have to worry about the nose digging into the breast or the baby not being able to breathe. The chin is what digs into the breast. And the nose is automatically free. So the latch is very important. And I think nurses are vital, absolutely vital in helping establish this, in helping establish that good latch. If the mother learns to latch right at the start, right in the hospital itself, that will not lead to more than half of the problems that could happen later. So that is the latch. See, as you can see here, you can see the differences between, this is this beautiful image that I've got from the BSIM website. I have mentioned all my sources in the end, so we'll be sharing that. But see, on your left, as you can see, this is a beautiful deep latch. Absolutely beautiful. Baby is completely, mouth is open wide, taking in as much, because we are not nipple feeding. It's called breastfeeding. The whole breast is involved. So the areola needs to go in, not just the tip, because if the tip goes in, there's pain. And if there's pain, there's something wrong. So this is, as you can see on the left, a beautiful deep latch. And here you can see a comparison with a shallow latch. Now, this shallow latch could lead to sore nipples, to lead to cracked nipples, could lead to a lot of pain for the mother. And even for the baby, it's not efficient, the milk transfer. The milk transfer is going to be very, very less. The baby will remove less milk, the mother will make less milk, and then it's just a vicious cycle. So this is a latch on the right, is a latch that needs correction. On the left, that's the kind of latch. So there's the reason I'm using this is because, it's until you see it, how would you know it? Like even I had zero idea about this. So it is important to see different latches to be able to gauge which could be a deep latch and which could be, as you can see, the baby's nose in the shallow latch has gone all the way into the breast. He's not taking the areola. He's taken barely just the tip. And bottle feeding works like that. Breastfeeding does not work like that. We need the whole areola in. The next basic is positioning. Positioning, because for some reason, like even when you see, first of all, there's not enough representation of breastfeeding in general. Like nowadays, earlier, like back in the days of, say, maybe not even our parents, of our grandparents, it was a very common sight. You would see there would be joint families. At any point of time, there would be like one small baby in the house, and it would be something that is generally seen. Now, unfortunately, we don't see it enough in real life. We all mostly live nuclear, and even so, the increase of bottles and formula feeding has just led to decrease in breastfeeding rates in general. And also, whatever little is shown in the media is a very romanticized version of breastfeeding, where the mother's just taking the baby and like they are like connecting eye to eye, and the baby just starts to feed. So unfortunately, it is not that simple. Breastfeeding is natural, yes, but breastfeeding is a learned skill. Both the baby and the mother need to learn how to effectively, efficiently breastfeed. So one of the things that really helps in that is positioning. There are many different positions that can be used. I'm using yet another infographic from the BSM website. You can see the very common one is the cradle hold, which is just taking a baby like this, which is just holding the baby like this. The other one is the cross cradle, where you use the other hand, this hand, to hold the baby. One second, I'm just trying to adjust my screen so you can see me better. Okay. The other one involves holding the baby with the opposite hand, and then using this hand to hold your breast and latch. That's the cross cradle. Again, like I said, baby has to be tummy to tummy. Tummy to tummy is best. Another one is the football hold. The football hold is something that works very well, especially if there are large breasts. If the breasts are very large and the baby is finding it very difficult to latch, the football hold works really well, because what you can do is you can just support the baby keeping pillows or something like that, or many mothers these days use like a nursing pillow, so you can turn it sideways. The baby needs to be on that pillow and the breast from here. Basically, that's how you feed. So essentially you can hold and then you can feed like this. So that way the pressure, the weight of the breast, the gravity is not like, pulling the breast down on baby's face. It is a very comfortable thing. That way also, if the mother has had a C-section, the baby is away from the stitches. The baby is nowhere close to the stitches, so the mother can comfortably feed. There is the laid back position, which is known as biological nursing, because if you remember when we saw the breast call photo, this is pretty much how it was. The mother is lying flat and the baby is just on the chest. That is either the mother can be completely flat, or many mothers don't find that very convenient. So you can put like a pillow or two and lie back a little bit. So at like say an angle of 30 degrees or 45 degrees or something like that. And the baby is just, so this is another great position in which the mother's breast is not weighing down on baby's face. So if you have large breasts, as in if you're a patient, if your mother who's like, delivered has large breasts, then the football and the laid back positions are very helpful because they take the pressure off the baby's face. This is a very comfortable position. Again, the mother is not crouching, so she is not hitting her stitches. The stitches are not paining. It is very, very comfortable for her because she can then relax. She, even if the baby is feeding for, whether it's feeding for 15 minutes or whether it becomes a half an hour session, there is no discomfort whatsoever because the mother is relaxed and the baby is also able to grab properly. And of course, a very important position, which unfortunately is not, there's a lot of misunderstanding when it comes to this position, which is side lying. So nursing lying down is actually very safe as long as you're practicing safe sleeping. Like, you're not doing it in any very soft sort of a surface. Thankfully, in India, it's a cultural thing to co-sleep. Like, this is not where generally in the West, even all the courses, all the programs that I've done, they speak a lot about, oh no, like, do not have a separate room and a separate crib, and like, try and co-sleep, be in the same room at least. Thankfully, it's a very nice cultural thing for us, where I think we've all grown up sleeping next to our parents, like, and definitely as infants. And maybe, like, maybe we slept separately after we were slightly older, but it's a part of the Indian culture, and it's a great thing because it gives the mother rest. It gives the baby a nice, again, another like, great position in which the breast weight is not weighing down. The mother just has to, so either she can lie like this. See, the baby is going to be like this anyway. So whether the mother's sitting up or the mother's lying down, the baby is still going to remain in this position, which is tummy to tummy. So it's not like the baby is sleeping. The baby is sleeping in every position that we see. I mean, apart from maybe the laid back in which it's on its stomach, but otherwise, every other position, it's the same position lying down. It's just that the mother gets a lot of rest. And this is a position that is very highly recommended to either mothers with large breasts or even mothers who have had a C-section, because, or even vaginal for that matter, because ultimately stitches, whether they are like, right at the abdomen or around the vulva, the vagina, it's painful. It's a time which is like, the mother's just getting used to this new life. And feeding lying down is very, very helpful in that matter, in which you're able to safely feed, you're able to be with your baby. Skin to skin happens because you're almost like a full body contact with the baby, and you can always use your other hand, the free hand, to support the baby's back if you feel like uncomfortable. So I think this is definitely a position that needs to be shown to mothers safely how to do this more often, because I feel the position, I think most other positions are fine, but cradle and cross cradle are probably the most popular positions that are like shown to mothers. But they should also be taught how to safely feed nursing lying down, because it goes a very long way in not only establishing but continuing that relationship, the breastfeeding relationship. Because if the mother is well rested, then she is more able, like, willing to be like, okay, no problem, like, if we have to work on the latch, maybe there's some other problem, maybe she's just tired, but she's at least rested. But when she's constantly waking up every 2 hours, she's not being able to sleep, she's just having to, like, she's in a lot of pain and she's constantly getting up to feed, then it becomes a very, and especially in families which are nuclear families, because today you'll see a lot of families. Okay, thankfully, another cultural thing that we have is that maybe the first month or 40 days, there is usually that period where you're with your family or at your mother's house, or your, at least there is some sort of an elder in the house. But we also have to keep in mind situations like coronavirus, like the COVID pandemic that's been going on, where people were just unable to travel to their daughters or their sons' places, or to their mother's places, to their parents' house. It was just a time when you had to do it all on your own. You could even, in fact, they did not even get the time to spend enough time in hospital, because most of them were expedited and sent home very early. So in that case, showing a position like this would be very helpful, because it would actually take a lot of the burden off the mother, where she can have the ability to rest and nurture her child at the same time. So here we are at the next basic of breastfeeding, which is demand and supply. Now, demand and supply is the absolute basic principle of breastfeeding. There are very few other things that matter as much as this, because breastfeeding has two components. One is milk production, and the other is milk removal. If any of them are affected, then the whole relationship can be a little on the downturn. Basically, if there is demand, there will be supply. Unless there are any pre-existing conditions that hamper the supply, that hamper the production of milk, which is not a very common thing. Generally, most mothers, like literally 5% of them will have a condition like, say, an IGT, which is insufficient glandular tissue, where she's just unable to breastfeed, or there will be certain conditions, maybe hormonal conditions, where it's impossible. But otherwise, mothers can feed, and it is supply and demand. It is just like that. It is like, as long as this is maintained, this will happen. So as you can see, every time the baby is basically removing the milk, there's a surge of oxytocin, which is that love hormone, which is that happy hormone that we want. And that actually sparks off prolactin, that sparks off milk production. That means more like milk is removed, the body gets a signal that, okay, there is a baby needs milk, we need to make more milk. And our breasts, our whole system, it's not like a little cup which just has this much milk and then it's going to take like 3-4 hours that acha uske baad thoda aayega. It's a tank, it's like a factory, it's just constantly making. If there is milk removal, there will be milk production, and it's just a cycle. Breast being soft, breast not being very hard, not being very engorged, that is not a sign, that is a false alarm. That is not a sign of the baby getting enough or the mother making enough. So there are different factors, there are other factors that we need to see, and we'll see that now. So the very, very important question on which this is actually, I think, the main point where a lot of breastfeeding relationships can make or break, in the sense they either continue the way they were, nicely, happily, or that's when the doubt creeps in. And this is where you have mothers saying that nahi, nahi, hai nahi, doodh hi nahi hai, so like, supply, like, we need to supplement, we need to give animal milk, we need to give formula milk. This is actually the only parameter on which you can gauge whether or not there is adequate milk supply and efficient milk transfer. So it's actually the first 5 days are important. Every day it's 1 pee, 1 poop minimum. And then it adds 2 pees, 2 poops, 3 pees, 3 poops, 4 pees, 4 poops on 4th day. 5th day onwards, it has to be a minimum of 6 pees, 6 clear pees, not diapers, because a diaper can take up to 2-3 pees also. So if the baby is in a langot, you can count the number of pees, or what you can do is you can just take an estimate of how much the baby pees. This is usually what happens is by this time the mother has already left the hospital and gone home. But this is important that the nurses, the healthcare professionals explain this to the mother, so that when they go home, because otherwise a lot of relationships start very nicely in the hospital, but they are not told what to expect or what to look out for. And then they have some assumptions, they have some myths in their mind. And when they go home is actually where the part about breastfeeding, adding any sort of supplementary milk or whatever, that can derail over there at home. So this is something which is very important, which needs to be conveyed to the mother repeatedly, what to look out for and when to actually be alarmed, and what to like not look at the size of your breasts or weight of your breasts or how much the baby is crying or how many times the baby is feeding. It's this is the primary indicator, which means if it is not following this, there are red flags. It means if for whatever reason the pee count is not up to the mark, or if the poop count is, if the meconium is not getting out, that is a red flag. It needs to be immediately addressed by a medical professional. But yes, so up to the first, so this is the first 6 days. Then up to the first 6 weeks, the baby should have minimum of 6 P's and ideally poop not ideally, actually in the first 6 weeks, the baby should poop every day. Because if the baby does not poop every day, again, there is something that needs to be checked out. Maybe there's no supply issue, maybe there's a transfer issue. Maybe there is a perfect transfer, but maybe something has ticked off for the supply. So that needs to be checked out. After 6 weeks, then 6 P's remain. 6 P's is actually the standard for everyone, even for adults. Like from 8 weeks to 80 years, 6 P's is a good count for everyone. The poops, however, I mean, a lot of professionals tell mothers that हाँ ठीक है, breast milk baby है, रोज नहीं poop करेगा तो चल जाएगा. That is okay after the first 6 to 8 weeks. So after the baby is around 1.5, 2 months old, after that, sometimes there can be days when the baby may skip a poop or whatever. It could be okay then, but not in the first month or month and a half. They have to be pooping every day. They have to release, flush out that meconium out of the system, get that yellow, seedy, mustard-looking poop, and that is the actual perfect indicator of whether or not the baby is getting enough. And these are very important hunger cues. This is another very a basic of breastfeeding, because what happens is, very unfortunately, we are even I was that person who I thought the baby only uh, like you know I mean their face. There are some cues in which they've done yawning, stirring a lot. Finally, they start. So when this, if you try to latch, if you try to put a breast,
Neha ma'am,
yeah,
there is some background noise coming in.
yeah, I just I think
There is some noise from your side, I guess.
no, not my. That's something. There's someone called Shrutika who unmuted.
Just a minute.
It's some.
Just a minute.
Okay. Yeah, it's muted now. Okay. Thank you. I was wondering, I got confused what happened. But anyhow, so we were at hunger cues. When the baby starts crying is actually, that is panic level. Matlab, by that time, the baby does not care about anything else. The baby only cares about being calmed down. It's like, imagine you've gone to a restaurant और आपने order दे दी, and then 5-10 minutes रुके ठीक है, 15 minutes, 15, 20 minutes, 25 minutes, you're like fine. Finally, when it's been over half an hour, 40 minutes, then you are agitated, you are angry, you are like आपको वो भूख सब भूल गई, you're not thinking about that at all. You're like, कहाँ है manager, कहाँ है, उसको बुलाओ, इसको बुलाओ, ये करो, वो करो. So even at that point, even if the manager comes out with a nice 7-course meal, आपको उसकी परवाह ही नहीं होगी, क्योंकि आप बोलेंगे वो खाना वाला छोड़ दो, क्या है, कितना waiting कराया. So this is that part when the baby is crying. The baby has already reached the point of no return. The baby is agitated. So then you have to calm the baby down. You have to rock, carry, hold the baby, calm the baby down. Then you start feeding. Because if the baby is agitated, and that's when you're like, oh, okay, acha, ro raha hai, and then you're trying to shove that, breast into the baby's mouth, the baby is going to very likely chomp down on your nipple. The baby is not going to be like, oh, let me latch deeply, let me be all nice and wide open and all that. Wo kuch nahi. Baby is angry, baby is agitated, baby's needs are not being met. So baby is now at that as we say in Marathi, kade load point, which is sort of a point where you don't want to go. So we need to look at early cues and mid cues. One thing that can interfere with this is swaddling. It's a very cultural thing, especially, I mean, I know definitely in Maharashtrians, because it happened with me. I swaddled my baby as well. But what happens is their non-verbal cues happen using hands. And when you swaddle them tight, it's like, imagine आप एकदम comfortable कंबल के नीचे हो, रात को बहुत ठंड है and you're feeling cold, like, or you're suddenly, or like, बहुत प्यास लगी है, लेकिन अगर आप बहुत ही comfortable हो ना, अगर blanket के अंदर, तो you'll wake up and you'll be like, छोड़ यार, प्यास तो लगी है, लेकिन अब यहाँ से उठा नहीं जा रहा है, like, I don't want to get up from here. So that's what happens when babies are swaddled. When you swaddle them so tight, it's so nice and comfortable for them that they don't want to get out. So even if they are hungry, even if they want, or they would like some sort of, like, some breast, basically, they will not wake up, because they are like, छोड़ो, मतलब ठीक है, comfortable है. But when they do wake up, वो तो पूरा मतलब, like, they'll bring the roof down. Then they are crying, वो एकदम purple crying हो सकता है, or it can just be that red faced crying. And that's when mothers panic. Mothers, parents, caregivers, everyone panics. They're like, oh my God, कितना रो रहा है बच्चा, like, कुछ तो दे दो. अरे दूध नहीं आ रहा होगा, कुछ और दे दो. Like, ये वाला दूध, वो वाला दूध, formula वाला दूध, वो सब, वो नहीं. That's not necessary. If we catch the hunger cues at the right time, then we can, evade a lot of those problems. Now, what are some breastfeeding problems? If all of these basics are not followed, most of the time, like 95% of the time, this is what happens, that all the basics that we discussed, which is your latching and positioning and getting enough, and right now what we saw, the hunger cues, if all of that is not followed, and of course the demand and supply, which means responsive feeding, constantly ensuring your milk is being emptied, your breast is being emptied, and the baby is feeding, as we saw in the true and false thing. If it is someone who's not, if the baby has not regained the birth weight, has to be fed every 1.5 to 2 hours, even if the baby is asleep. Even if the baby, usko utha lo, ya fir sote hue only try and latch the baby, but the baby needs to feed. Another thing, so these actually may lead to breastfeeding problems. So what are the common problems that we see? So the most common problems are these, which are your sore nipples, excessive, so sore nipples, as we said. Why do they happen? Poor latch. Like 9.9 times out of 10, it's a very shallow latch that is leading, because breastfeeding should not be painful. If it is painful, कुछ तो गड़बड़ हो रही है कहीं पे. Like, it is something you should never tell a mother saying that, अरे हाँ थोड़ा तो दुखता है, starting में नया है ना, तो थोड़ा दुखता है. नहीं, it should not pain at all. If it is paining, it has to be taken seriously and it has to be dealt with immediately. So sore nipples hai, cracked nipples hai, with some mothers, it reaches the point where it's beginning to bleed. That is a classic sign of a shallow latch. Excessive crying. Excessive crying, like I said, you have to figure out whether it is a false alarm or whether such may, like, there is some issue, because the crying is the only type of method of communication that the baby is doing. So we need to understand why this is happening. You check different things. Kabhi, if they soiled their diaper, maybe they're feeling too cold. Now imagine they've been so nice and cozy in the womb for 9 months, and suddenly आप उनको बाहर, की दुनिया में जब वो आते हैं, everything is too much. There's बहुत ठंड है, बहुत गर्मी है, like माँ बहुत दूर है. Actually, that's the number one reason. If the babies are kept close to the mother, the crying is also a lot under control. Inability to latch. Inability to latch is something that is very important. बहुत बार, maybe you're trying everything, you're trying that perfect hold, you're trying this, you're trying that, but it's just not happening. Then we need to understand why. Because there could be various factors involved. One of them I've mentioned here, which is oral restrictions, which is unfortunately a slightly overlooked topic, but it is something that needs attention. So inability, if the baby is just not latching, there is a need to figure out why. Slow weight gain. Slow weight gain is again, before, it is definitely one of the, like I said, getting enough, we have to look at the pee count and poop count. But apart from that, we also look at the weight gain of the baby, and the weight gain of the baby not in 1 week or in 10 days, because usually that's the time when babies are losing weight, or just about being at that same level or beginning to gain weight, not yet. So if you have to look at weight gain, it is usually at the end of a month or at the end of 3 weeks to a month at least. If it is moderate, if the baby is on a set percentile, it can be anything. See, we are all different. Every baby can't be a 96 percentile baby. There is and also more importantly, there's a lot of representation of Caucasian babies, Caucasian matlab foreigners basically. They're genetically got chubby babies, they have larger, they have taller, they have heavier babies. But Indian babies cannot be compared to the same thing. We have to look at the baby's growth, not at global percentile charts only. Why is this baby only at the 40th percentile? But if the thing is steady, if the percentile growth is steady, then that is okay. I mean, it is not something which is inconceivable, because every one of us can be at a different percentile. We can't all be in the same weight bracket or height bracket or anything. But however, if there is slow weight gain, again, before immediately going for, ye do, de do, wo do, de do, try and figure out why. Most times there is some issue there. Again, it is very directly involved with the inability to latch. Maybe there's inefficient transfer of milk, which also takes us to the next issue, which is low supply. I mean, I think 9 out of 10 times if a mother is coming for some help, the first thing will be like, mera to kuch doodh hi nahi. Like, my baby is just not getting any milk. वो तो ऐसा ही मतलब I'm trying to latch, मुझे कुछ दिखता नहीं, कुछ ऐसे दूध में दबा के देखती हूँ, कुछ नहीं आता. And the baby is also like, वो ठीक है, वो पीता है, लेकिन कभी मुझे I've not seen ऐसे दूध आ रहा है उसके मुंह से बाहर आ रहा है. और of course breasts are very soft, बहुत ही like कुछ ऐसे hard नहीं, ऐसे full नहीं लगता. So no, that could be a false alarm. If there is a genuine case of low supply, that needs to be checked out. It could be hormonal. Thyroid is a major contributor to this. A lot of women with hypo or hypothyroid have a problem with either their supply itself or with the letdown. So that if they, however, there are breastfeeding friendly medications for thyroid, and if they are on a proper course of medication and if they take it regularly, it can be controlled. The levels can be brought down, can be normalized, and then usually there is no issue. Another thing is PCOD, which is now a very PCOS or PCOD is a very common thing, a lifestyle disease as such. So that could also be a reason. Again, there is a way. There are PCOD. I mean, a lot of people go for medication. Personally, because I myself, I've had PCOS for almost a decade now, and I believe exercise is the best way to control that. But yes, point is there is a way of controlling that as well. Next problem is a fast letdown. Like on one hand you have someone who says kuch doodh nahi aa raha, and the other hand you have someone who's got too much of a letdown. Matlab, the minute the baby latches, there's a jet spray. Now that is again, it should not be brushed off as अरे वाह ये तो बहुत दूध है आपके पास, no tension. No, उसमें भी problems हो सकते हैं. Fast letdown is very problematic. It's like, imagine I'm drinking water. If I'm drinking water, this is a small nice little mouth, very convenient, मैं पी सकती हूँ. लेकिन suddenly मैंने अगर bucket ली और मेरे मुंह पे empty कर दी, तो मैं सांस भी नहीं ले पाऊंगी. So that's exactly what happens with a baby with a fast letdown, that the baby is just not able to control. It's too small. Uska muh, uska size, and he's not able to move. So he's not able to control the milk. So that's when baby will be fussy. He'll be moving his head back constantly. He'll be rejecting the breasts, and that could lead to a nursing strike, basically. So fast letdown is also something which is very important to figure out. Then engorgement. Engorgement is again something which needs to be looked at. We need to be constantly, like I said, emptying the breast. So if there is engorgement, it means it has been too long. 2 feeds के बीच में बहुत time gap हो चुका है. Maybe 3 घंटे हो चुके हैं, maybe 4 घंटे हो चुके हैं. Engorgement or oversupply, I mean, it needs to be dealt with immediately. Either it's a temporary engorgement ki, okay, maybe the mother forgot or she slept a little. Maybe baby was sleeping, so mother also overslept. इसलिए engorgement हो गई. But the easiest way to remove engorgement is to first hand express a little bit, hand express, hand expression is actually a great technique that needs to be shown to mothers in the hospital itself, because it's a great way to relieve yourself of the fast letdown, of an engorgement. And it's a great way that way you don't have to invest into pumps, because pumping का कुछ और ही problem है. मतलब pumping, if you start very early, it can lead to an oversupply problem. So pumping, ideally, I do not recommend to mothers. Thankfully, in India, we have a great maternity law which gives us 6 months. Even if it's a working mother, she gets 6 months at home with the baby, unlike the US where they don't have any sort of maternity benefit or leave. So if we don't have any kind of an absolute important rush to start the baby on something else, avoid the pump. Avoid the pump until the supply stabilizes, because then that can lead to other problems. Hand expression is great. Hand expression is just basically you take the breast like this. You can hold it in a C latch. You push it in, like you take your thumbs, push it in, and then you push it towards the areola. You just push it in and then towards the areola. So that actually what happens is, if you have engorgement, actually more than engorgement, even the fast letdown, even oversupply, you express a little bit of the milk. You help a mother, teach her how to hand express a little bit, and that will lead to I think we have taken one. Oh, thank you. Yeah, so that can lead to being able to stabilize the supply. Suddenly, it won't be too much for the baby. The baby will be able to deal with it. Plug duct mastitis, again, it's almost a continuation of engorgement. Engorgement is first step. The second step, if उसपे कुछ किया नहीं, ऐसे ही रखा, then because the body is constantly making, it has to be removed. The milk has to be removed. If it's not removed, or if the latch is not right, it's not removed efficiently, that could lead to plug ducts, which in turn could lead to mastitis. Mastitis is when it's accompanied with fever. There's a hardness, a lump in the breast. You can visibly see the breast is much larger, and there's a fever that accompanies that. So low grade flu like symptoms, that needs attention, but that could go to abscess, that could lead to a necessity of interventions like aspiration. So all of this can just be barriers in the breastfeeding journey. So any of this at the point of engorgement itself, you need to address all of this. And we need to, like I said, constantly remind mothers about the part where it is a supply and demand thing, where if the milk is being produced, it has to be removed on the regular. Supplementation, there are a variety of reasons that we don't have enough time to discuss everything in detail, but there is a variety of reasons where supplementation may be necessary. It could be a temporary thing, it could just be a transition sort of a thing, but ideally we don't reach that phase in the first shot. We go through all of this, we try to tick off things, we try to check where the problem is, and if all of it is fine for whatever reason, it's just not working out, there is some issue, then you reach the part where you are talking about supplementation. You don't jump to supplementation directly. And even in supplementation, ideally we use alternatives to bottles. Thankfully, we have paladais, or as we call them, bondlas in Marathi. We have that little cup with the beak. That is a great way. An open cup is a great way of giving baby, or it's just a simple katori and chamach. That's a great way, especially with newborns when their demands are very little. They barely take like a few, dozens of ml in a feed, like maybe 10 ml, 30 ml. That is perfectly fine. Ideally not going to the bottle directly, because the minute the bottle enters the picture, the breast can get affected. The breastfeeding can get affected. So if for whatever reason medically supplementation is necessary, we ideally look at an alternative to bottles. If as a last resort a bottle is necessary to be introduced, the bottle also has to be introduced in the same manner as we introduce the breast, which is you hold the baby at a 45-degree angle. You hold the baby close to you as you would when you're nursing. You don't just हाँ ठीक है bottle है तो उसके हाथ में थमा दिया. No, you protect the breastfeeding relationship. You make the bottle as close to a breast as possible. We want a bottle which has a wide. We don't want a very narrow sort of a mouth. We want a wider mouth, and we start here. I don't know if you can see. We start again by stroking the nose and resting it on the upper lip. When the baby opens the mouth, is when you put it in and you hold the bottle almost as parallel to the ground as possible. आप बस इतना ही tilt करना है कि the milk should reach halfway through the nipple. It should just reach the nipple, so the baby has to work at the bottle. The minute you hold the bottle like this, the bottle just drips milk and the baby कुछ नहीं काम करना ही नहीं पड़ता. Like, it's very, very easy for the baby. So then they can start rejecting the breast. So the bottle feeding should also be paced bottle feeding and responsive bottle feeding. If that is, again and again, if we reach the stage of bottle feeding, ideally we don't go to supplementation or bottle feeding at all. Also, we try to look for as slow flow or no flow of a nipple as possible. The minute you see a nipple is drip, 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 that means it is going to interfere with the breastfeeding relationship. Finally, the most, like I said, important, and this is something that needs a knowledgeable professional, ideally a pediatric dentist or someone who's an IBCLC with an experience with ties. Because the thing about ties is there's a lot of theory you can study about them, but you also need a lot of practical hands-on experience. The problem is right now, either ties are being dismissed, tongue ties, lip ties, they're being dismissed entirely, or they are being overly diagnosed, over intervention. So we have two extremes right now. So it is important. We have to look at all of these factors and then finally come to the point where you're like, okay, maybe this is because of an oral restriction. If it is an anterior tie, it's easy because, aapko dikhta hai. Like anterior tie is very easy to be seen or diagnosed. This is right at the tip. But if it's a posterior tie, if there are like levels of buccal ties, that they are more difficult to diagnose. So we have to refer the baby to a pediatric dentist, someone who is experienced in this, or to a knowledgeable, experienced LC, ideally an IBCLC or even a CLP or other qualifications, lactation professionals who are experienced in the same. So these are some of the common issues. And why are we here? We are here to do this, which is the celebration and a promotion and a preservation of this amazing thing, which is breastfeeding. We are here for the World Breastfeeding Week 2021, which has been celebrated annually since 1992. And what is this year's theme? This year's theme is protecting breastfeeding as a shared responsibility. It is not only the onus of the mother and the child, while yes, they are the central figures and they should be the primary decision makers of this beautiful relationship. There has to be community support that, like, because it's a responsibility. It is not just usko pilana nahi hai, usko pilana hai, ya fir usko pilana hai. It's not about her. All of it together, it affects all of us. It affects the world, it affects each person, and it affects the planet. So these are the objectives, as most of you may know, about information, spreading information, anchoring breastfeeding support as a vital public health responsibility, engaging with people, talking about things, discussing things, and of course, galvanizing action on protecting breastfeeding. So something like this, like the webinar we are at right now, is a great way. We are pretty much taking up, like, all of the objectives that have been set for the World Breastfeeding Week. And it is an absolutely amazing thing. There are a variety of reasons why we need to protect breastfeeding. As we all know, it's the biological normal. It is amazing for the planet. It has got a host of planetary benefits in terms of just saving this planet. There's so much water that's saved. There's so much plastic that is saved when you're just breastfeeding. But there's no apparatus that you need. Like, buy this, buy that. There's so much consumerism and capitalism that we can cut down on. It is the most efficient way. However, it is just not being done enough. Almost 2 out of 3 are not going through with the recommended 6 months. Breast milk, as we know, is a complete food. It is like, it is literally like as ready, as sterilized, as pasteurized, safe, clean, and most importantly, it contains antibodies, which is, especially in this past year, it has proven to be absolutely essential and beneficial for mothers, because a lot of mothers have either restarted their breastfeeding journeys or they have not stopped breastfeeding their older children. They are like, going on to a full-term breastfeeding because they know that there is nothing else right now that protects their kids against COVID, but breastfeeding has been proven to have, breast milk has been proven to have antibodies for even COVID, which is like an unheard of pandemic that we are facing right now. It has everything that it needs until 6 months exclusive. Even between 6 months to 12 months, it provides more than half the nutrition. So it needs to be the primary source of nutrition for a baby. And beyond 1 to 2 years, also, it has a huge benefit to the child and the mother both. As you can see, mothers' risks of breast cancers, ovarian cancers reduced. Breastfed children in general less prone to asthma, less prone to diabetes. The main problem that happens and the reason we need to protect breastfeeding is just the inappropriate marketing of nutritional substitutes. And of course, at the end of the day, breast milk, breastfeeding is a human right. We keep talking about the milk, we keep talking about, oh, but science has progressed fine. If you don't have that natural milk, you can always give scientifically formulated milk. It is a human right. It is part, it's like how talking, breathing, it's like it comes naturally to us. This is a human right. It needs to be protected, respected, and fulfilled. And there are so many non-nutritive aspects to breastfeeding. There is so much that is involved in breastfeeding, which is not just about the milk. And this is more so as the child grows older. So we have to protect this. Um, of course, all of you know the UNICEF and WHO recommendations, which is optimal breastfeeding. Within 1 hour, you initiate breastfeeding within 1 hour, irrespective of whether it's a C-section or whether it's a vaginal birth. You exclusively breastfeed for the first 6 months of life, and then you continue breastfeeding up to 2 years or beyond, not up to 2 years. It says or beyond, which means it is a mother's choice. The only decision makers in that should be the baby, the infant, the toddler, and the mother. Um, Along with, of course, the introduction of complementary solids after 6 months, not 3, not 4 months, 6 months. There are a lot of factors that involve there. So 6 months exclusively breastfed. It has everything. There's nothing. There's no need for water. Bahar, even if it's 45 degrees, 50 degrees outside, breast milk is 88% water. So there is zero necessity to provide separately water to the infant as long as you are breastfeeding on demand. You're breastfeeding sufficiently. Then there is no need for any external. How can you help? Wow, this is the absolute crux of why we are here. I think you are vital. All of this, it starts with you. You are the first point of contact that a mother has once she has birthed the child. Technically, you're also a very important point of contact before she's birthed the child, while she's pregnant. The antenatal education needs to begin there. That itself is a great thing to do. But for whatever reason, if that part has been missed out, for whatever reason, the mother is not well informed about this before the baby, while and during that moment that she has birthed and now the baby is out and ready to feed, you are that first primary point of contact. And I'm witness to this because I remember from my own experience almost 3 years ago. I remember everything, but there are two nurses that I remember distinctly. One nurse was the one who brought my baby to me. I had a C-section, so I was knocked out for 3 hours. I did not initiate breastfeeding. I mean, it wasn't initiated for me in the first hour. I think he was kept in a warmer, a thermal warmer, and I fed my infant, I think about 4 hours. I think I birthed him around 9:45, and I fed him around 2:30 in the morning. So almost 4.5 to 5 hours he was away from me. Finally, when I got back to my senses, there was a very empathetic nurse who brought him to me, and she brought him close and she just like gave it, and she was very tender, she was very kind. She helped me a lot because it was like the anesthesia was wearing off and I was in so much pain, and she helped me keep a pillow, she showed me how to keep pillows, she helped me latch, and I would never forget her because that got it started. And then at that same maternity home there was another nurse who was so absolutely rude. She was like, I mean, I wasn't like sure of it, but like, every time the baby would start crying a little bit, like thoda sa, and there was one nurse, she was a night nurse, and there was this day nurse who every time my baby started crying, she would just come in, take my baby, take him to the nursery, take him away, and begin giving him formula. And there was no consent, there was nothing. It was just like, I was like, "Acha, aap kya kar rahe ho? Matlab, like, what is happening?" She's like, "नहीं, बच्चा रो रहा है ना, तो like, anyway, अभी तो दूध नहीं, अभी तो C-section हुआ है, अभी तो दूध नहीं आया होगा, तो हम उसको formula दे देंगे." And there was no kindness, there was no information also that she was giving me. She was just telling me what she's doing. She was not helpful at all. So those are like, I met two completely diametrically opposite nurse experiences during my own, and both of them are unforgettable, because thankfully I had the other one. Thankfully, every evening when her shift came on, I used to ask her all my questions, and she used to very calmly, very coolly, she'd be like, "No problem, don't worry about it." So, like, just in general, but yes, it starts with you, and it is so important. We have actually already discussed a lot about the things that will follow now. You just find out different ways about breastfeeding. This is a classic example. Your college has organized this wonderful webinar, which is a great way of understanding more than what's in your syllabus. Another thing is to talk with mothers, whether while they're pregnant, while they've just birthed their babies, about how they want to feed. Why do they want to do that? You can discuss all of their issues or expectations or whatever with them. You can make support as part of the care, of the standard procedures. Everyone has a list of standard of SOPs that, okay, we do this, 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 and you just integrate breastfeeding. We can integrate breastfeeding as part of it and make it easier for mothers to be able to get onto this easily. Yes, keeping baby skin to skin is important, and the minute you take contact away, the association, the relationship is lost. You can develop teams. Yes, we can develop teams. We can work together. There are lactation professionals. There are IBCLCs who are trained specifically in this. So if for whatever reason, because you all have so much to do, I mean, there's so much to do in a hospital or a healthcare setting, that if you think it is something beyond your bandwidth, like you just don't have the time to sit with someone one-on-one and deal with it, you can always, instead of leaving them at their own thing, you can always forward them, move them to a skilled care professional. And of course, you continue with this support after this. So you prep them with all the support that they need in that first 1 month, because that's the crucial time. That's when they can either have like great care and be like, wow, this is great, or they'll derail and they'll get off breastfeeding. So we can equip them with support, give them, tell them places, give them more sort of resources where they can take help. And this is actually something that Madhuri ma'am has already addressed, so I won't go into a detail of it. The baby-friendly hospital initiative, something that you all are learning. I believe your third year syllabus has this in detail, so most of you will already know about this. The BFHI is basically a way of preserving and protecting breastfeeding. And just there are 10 steps to successful breastfeeding, which is exactly what Madhuri ma'am spoke about an hour ago, like before I came on. So we'll just quickly glance through them. Hospital policies, staff competency, antenatal care, very important, because that's a great time to get it started. Baby is not there, everyone is calm, great time to learn more. Then we have care right after birth. Like I said, it starts with you. You're the first point of contact. Then you support mothers with breastfeeding in whatever way possible. Either you can increase your own knowledge base, or you can then forward them on to someone who is a more skilled and more concentrated sort of a professional. Supplementing if need be. There's a way of doing that, like we discussed earlier, a responsive feeding method, paced feeding method. Rooming in, very important, keeping mothers together as much as possible. Responsive feeding, yes. Not limiting, you always watch the baby, not the clock. The baby will give you the cues, the baby is completely equipped with everything, with all the reflexes, all the insights that they need of continuing this. Bottle feeds and pacifiers, yes. I mean, you let mothers know what the risks are, because all of them have risks in general. So it is important to give mother the information so that she can make that informed choice. And of course, at discharge, you give them community support, you equip them with resources, you can tell them that, see, you can join. So in the next slide, I have a list of, so this is a great compilation of continued support. Number one, like I said, is where I came from, where I got that support when I was a completely lost in the dark new mother. 3 days after I went home after my C-section, I had zero idea what to do. And this is that group that came to my rescue. It's called Breastfeeding Support for Indian Mothers. It's a fantastic Facebook group. It has 1.5 lakh members almost, and it is just peer-to-peer support, information. They also have a website now from which we have a lot of our content today. It's bsim.org.in. I have it listed later. Then Shishu Poshan is an app which has been developed in association with BPNI. It is a great app. It is an app by BPNI Maharashtra, I believe, and UNICEF. It is available on Android, and it is available in 3 languages, in English, Marathi, and Hindi. So especially for you all who are learning, I mean, you're in Aurangabad, I'm in Mumbai. If you do go on to work within Maharashtra itself, this is a great app because it has so much information, perfectly factual information. Same with the BSIM website. The BSIM website is available in 10 languages, in fact. So it's available right from your Tamil, Telugu, Hindi, English, Marathi, Bengali. It is available in a host of languages. So you can use these resources. You can refer mothers to these resources. Other groups are the LAL, which has an India wing as well. BPNI, which is the Breastfeeding Promotion Network of India, and ALPI, which is the Association of Lactation Professionals, which has both BPNI and ALPI have a great database of professionals that you can always try and see who's in your city, in your area, and refer your mothers there if there's a need. So I'll conclude with this very simple thought, which I love. It's one of my favorite thoughts by an ex-US senator called Barbara Mikulski. And it is, each one of us can make a difference. And together we make change. We do not aim for the stars, like we are not like, oh, but how is one thing gonna do? But if we start from each one of us, we do a little bit, we do that little extra effort to make a change, to make a difference, it will lead to change, and it is inevitable. So yes, these are my references. If you want, I'll be sharing a handout with your with the ma'am, so you can always take it from there. And that's me. I hope it wasn't too boring. And thank you so much for having me here. It has been an honor. It has been an absolute privilege to be able to speak with all of you, to be able to present at this absolutely wonderful webinar. And it is the need of the hour. And I'm so glad that your college taken this initiative to establish something like this, to promote, to speak about something which is so important today. So thank you so much. Thank you so much for having me. Thank you.
Thank you, Neha ma'am. It was an excellent presentation.
Thank you. Thank you.
It was an excellent presentation with a lot of demonstration, starting from the bottle to the dummy breast to the positions and everything. It was really fantastic one. We are very happy to have you on this occasion today. Thank you so much, ma'am. Thank you.
Thank you so much. Thank you. It was an absolute honor. I loved it.
Yeah,
thank you.
Yeah, thank you, ma'am. Moving on to our next session, new moms often find themselves on receiving ends of all kinds of advices. Most people are genuinely trying to be helpful, but unfortunately, few topics attract more heated debate, misinformation and confusion than breastfeeding. May I welcome Ms. Merlin Shinde, lecturer in J. Mother Teresa College of Nursing. Madam will be talking about the impacts of culture on breastfeeding.
Good evening, everyone. I'll be speaking on cultural barriers on breastfeeding. And in our Indian scenario, the breastfeeding, it comes very easily or traditionally to our mothers. But because of certain cultural barriers or certain cultural beliefs or practices, the exclusive breastfeeding is not being practiced in our country. So on this occasion of Breastfeeding Week, as we are celebrating it every year from 1st to 7th August, to raise awareness and galvanize action on breastfeeding and related issues. So one of the related issues for breastfeeding is cultural barrier. What is culture? Culture is values, beliefs, norms, and practices of a particular group. Although traditionally India remains a country which supports breastfeeding, psychosocial and cultural barriers still exist for effective breastfeeding practices. So as healthcare professionals, we should be aware of them and be able to assess the cultural practices, whether they are harmless or harmful to the mother and baby, and accordingly we can counsel them. So we will see some of the common cultural beliefs and practices that can be harmful to the baby. So many of the cultural beliefs we already know that are there. We have been, maybe we have seen it in our families, or maybe with, among our friends or relatives, certain cultural beliefs or practices that are there regarding breastfeeding and also regarding the newborn care. So the first thing is regarding the colostrum. So colostrum, it is not been given, or it is discarded by many of the mothers because of the old thinking, or maybe because of the belief that old milk that has been in the breast for months and is not good for the baby. So it has been discarded. So it should not be done, because colostrum is rich in essential vitamins and has antibodies, has IgA, that is immunoglobulin A, which helps to develop newborn's immune system. And the next common cultural barrier or the cultural belief is a baby need to be given honey or gutti before the first feed. So gutti like jannam, gutti also they say. So this practice is not good because it may be unhygienic and it can predispose the baby to infections like GI tract infection, and maybe to inflammatory bowel diseases, etc. So many other infections can be there to the baby because of honey or gutti, so that should be avoided. Then the other belief is infant needs water in addition to being breastfed. So breastfeed is already rich in water, and there is no need of giving additional water with breastfeeding, especially during the first 6 months. So during the first 6 months of the baby's life, exclusive breastfeeding should be done. And the other belief is a mother who becomes pregnant must stop breastfeeding. So breastfeeding does not have any effect on the pregnancy or the quality of breast milk. So it can be continued during pregnancy and after the birth of the newborn. So a mother can breastfeed even when she becomes pregnant for the second time. Then the other belief is no drug is safe to take while breastfeeding. So there are limited number of medications that are contraindicated during breastfeeding, as they can pass through the milk to the newborn. But most of the medications can be taken safely after consulting the doctor. So most of the medications are safe during breastfeeding, and if some medications they are contraindicated, even the prescriptions or the leaflets that are there in the medications medication box, they will give the information if it is contraindicated during the breastfeeding. So usually most of the drugs or most of the medications are safe during breastfeeding. And the other myth or misconception is stop breastfeeding if the baby has diarrhea. So that should not be done. Breastfeeding is ideal medicine for sick baby, as it protects the gastrointestinal system and helps fight the illness. It also provides fluids to prevent dehydration. So breastfeeding should be given during diarrhea if the baby is having diarrhea. Then do not breastfeed right after cesarean section. So even after cesarean section, immediately within half an hour or within an hour, breastfeeding should be given to the baby. So there are certain things that as healthcare professionals, we know that it is not very much possible to give breastfeed within a half an hour to the baby soon after cesarean section. But as healthcare professionals, we should take care, or we should find a way to give breastfeeding in an hour or within half an hour to the baby. The next myth is the amount of milk secretion in the lactating mothers depend on the size of the breast. So this has already been discussed by Neha madam, and she has given the quiz on this question. So naturally, the milk secretion does not depend on the size of the breast, because the milk secretion or the milk production mainly depends on the secretory glands that are present in the breast, and usually all the breasts, they have the same level of secretory glands or same number of secretory glands in their breast. Then there are some myths or some cultural barriers which are harmless. So as we are living in Indian culture, or we know the Indian culture where there are so many myths and beliefs that are there, but certain cultural beliefs or practices may be harmless. So we should know as healthcare professionals that what are those cultural beliefs or practices that are harmless to the baby. So in certain areas or in certain uh, places in India, what they do is they rub papaya leaves and stalks of sugarcane on the mother's breast for good and sweet milk. So if the mother is giving proper breastfeeding, then it is a harmless practice. Then again, the other cultural belief is a picture of breastfeeding mother seated in front of waterfall increases the milk production. So with this, if they are having such belief and if they are giving the best breastfeeding, then also it is a harmless practice, because the mother can keep a picture in front of her and of the mother who is breastfeeding and sitting in front of a waterfall. So that does not create any harm to the baby or to the mother. And the other cultural practice is seclusion of mother and baby for 40 days. So that is usually everywhere it's been seen. And it's considered that the bonding of the mother between mother and baby is good because of that, and prevents infection to the infant. So this practice is also harmless unless and until the room the baby and the mother is living is well ventilated and it is well illuminated. So then it is a harmless practice. So as healthcare professionals, we should know what is harmful and what is harmless cultural beliefs and practices that are there. And from that, we should try to educate the mother and the family, mainly the cultural practices or beliefs that are harmful to the baby and to the mother. So how we can overcome the cultural barriers as healthcare professionals? First is teaching the society all aspects of breastfeeding and educating them about wrong practices. Then give mother the confidence that breast milk is sufficient for the first 6 months of baby's life. Understanding her need for support or privacy during breastfeeding. Making sure that honey, gutti, or water is not being given to the baby. Discouraging cultural practices which are harmful for breastfeeding by proper counseling to the mother and to the family. Then one of the important thing in India is India has strong family oriented culture. So we can educate the family members and they can be the best help to the mother during the lactation period or during the breastfeeding period. So this is in brief regarding the cultural beliefs and practices that can hamper or hinder breastfeeding. And there are many such beliefs and misconceptions regarding breastfeeding and newborn care, which has to be dealt effectively as a healthcare professional. So wherever we can see, if we see any cultural practices or beliefs or any myths that are there, we have to educate the people, educate the society regarding it, and try to overcome them and try to educate them in a right way. So this is in brief regarding the cultural barriers or the impact of culture on breastfeeding. Thank you everyone for your patient listening. Thank you.
Thank you, ma'am, for discussing about the cultural barriers, all the crazy barriers which are still followed by making the woman sit under a waterfall or rubbing the papaya leaves over her breasts. These are all misconceptions at the end of the day. Thank you, ma'am, for the wonderful session. Now we'll move on to our next session. The transition of the switching of role from a simple woman to a responsible feeding mother itself bounds her with lot many confusions and energy shifts. Therefore, not only the mother, but her spouse and the family play an equal role in this new adaptation of hers. May I now take the privilege to call upon Ms. Rashmi Podwal. Madam is an international board certified lactation consultant, currently practicing in Pune since 13 years. Madam is in charge of Nectar Human Bank, Milk Bank at KM Hospital, Pune. Her areas of interest are preterm nutrition, supportive interventions for primary mothers, and low birth weight babies. Since past many years, Madam has been actively working in teaching and training medical professionals who are aspiring for lactation consultation services. Madam is also social media free by posting many quality information videos, online blogs, and has written several articles in renowned newspaper. Today, Madam will be discussing about breastfeeding support, role of spouse, family, and society, and human milk banking. We welcome you, ma'am.
Thank you so much. A very good evening, everyone, and a very happy World Breastfeeding Week. I'll just share my screen. Is it visible?
Yes.
Yeah, okay. So my topic for today is protect breastfeeding, role of spouse, family, society, and I'll also be talking a little bit about human milk banking. Uh, A bit about me, ma'am has already given my introduction. So I've been working as a lactation consultant for the last 13 years. I've been working at KM Hospital, Pune for 7 years. Along with that, I was working at Sayadri Hospital, Nagar Road. I'm an IBCLC, a certified breastfeeding specialist. Last 3.5 years, I've been managing and the working and functioning of a human milk bank. The name is Nectar. I'm also an NICU enteral nutritionist, a baby sleep consultant, pregnancy lifestyle and nutrition expert, and I'm a coordinator for lactation consultants group of Pune, lactation support team India, and a human milk banking network of Pune. Why I got interested into becoming an LC? So 13 years back, when nobody actually knew who a lactation consultant is, people were not even aware. I am basically a nutritionist, and I got an opportunity to work in the best NICU, one of the best NICUs in India, in KM Hospital. So it was probably the first time I was seeing such tiny babies, from 500 gram onwards, and the environment in the NICU is mesmerizing, and I really started loving that work. I received a lot of support and encouragement there from the chief head of the NICU. Then I realized that nutritionists do play a role in the NICU with the babies, starting from day one, because mother's milk is the first nutrition that we get. It is the ideal nutrition, is the tailor-made nutrition. So definitely there was a role. And plus, as I continued my internship, I understood there is a lot of satisfaction, as we all, have that satisfaction working with babies and mothers, especially preemies. I have a lot of experience with that. So then I decided to choose this as my career path. So we have gathered here today. We are celebrating World Breastfeeding Week 2021. Today is the last day. And this year's theme is Protect Breastfeeding, a Shared Responsibility. So basically, as the earlier speaker said, it is not just the responsibility of the mother, but it is the responsibility of a lot of people who should come together and take that responsibility. Then only the breastfeeding rates in India would actually increase. We are still struggling to meet the optimum goals of exclusive breastfeeding, of early initiation. So there are a lot many people who play a part: family, spouse, friends, relatives, colleagues, neighbors, healthcare workers. Definitely lactation professionals have a major role to play. Community or society as a whole, employers, the decision makers, celebrities or influencers, educators. So I think we are doing that right now. We are educating a lot many nursing students and about breastfeeding. investors, government, NGOs, media plays a major role, the lawmakers. So everyone should come together and take this responsibility. What does a breastfeeding mom need? So there are a lot many things that a mother needs. She needs to be aware about breastfeeding. She needs to have that knowledge, at least basic knowledge about breastfeeding. She needs that guidance in her antenatal period, perinatally, during and post delivery, post birth. She needs that training about breastfeeding techniques, latching, positioning, a lot of breastfeeding support, emotional support, mental support, very, very crucial. Mom might need somebody to just, patiently listen to her, understand what her difficulties are, understand where she's coming from. She needs kind words, empathy. She needs somebody to understand what she's going through. Also, she needs somebody to help her and guide her with troubleshooting of some problems. So the problems that were discussed earlier, flat nipples or soreness, engorgement, mastitis, whatever. She needs somebody to help and guide her through that and to get rid of those problems at the earliest. She needs constant motivation, good food, good nutrition, loving touch. She needs time to rest, sleep. If she's using breastfeeding aids like a breast pump, maybe a nipple shield, supplemental nursing system, any sort of aids that she's using, she would need advice regarding that, how to use them, the techniques, the hygiene, everything. She might need help with other household chores, obviously, so much of her time would be taken up by breastfeeding, so she would need help with other work that is being done. Affordable and accessible care, all mothers deserve that. She also needs a non-judgmental and unbiased approach. So mother would always want to have somebody who will not judge her for whatever decisions she has made. In fact, somebody who would try to understand why she has made those decisions. Time to relax, time to unwind, freshen up, somebody to boost her confidence, positive, give her that positivity, and keep on reassuring her throughout her journey whenever she feels a little demotivated or she is stressed. She needs that constant reassurances. So what basically influences breastfeeding? There are many factors. Research review states that the families are more influential for the mom and in her breastfeeding journey than the professionals. Women often rate that partner influence is higher than all others. There's diverse cultural influence that we just heard ma'am speak about. Nowadays, there are so many nuclear families wherein if there's just wife and husband, then obviously the husband has a much bigger part to play. We are all facing the global pandemic, and mothers who have delivered in the last 2 years, it has been a really tough time for them. They had to manage a lot on their own. There were restrictions on help that was available. There were restrictions on the visitors. So many mothers could not go to their mom's place, or they could not have too many people and relatives along with them. There are mothers I know who were in the hospital and they were alone in the hospital. Even post C-sections, they have managed alone because maybe she was COVID positive or something like that. So what does the research state? There was a research that was done in China. It showed that when mom and dad, or like mother and father, were educated together, expecting mother and father, they saw that there was much improvement when a combined education was given to them than only when it was given just to the mother. So they saw that exclusive breastfeeding at 6 months was 51% compared to 26% when only mothers were educated. Similarly, infant formula at 1 month, the use was only 4% when both dad and mom were educated, compared to 24% in when only mothers were educated about it. Use of infant formula at 6 months was 20% compared to 44%. So these mothers were found to be happier. These fathers were more caring. They were helping more in the housework, helping more when the things got difficult. In Vietnam, again, there was another study wherein similarly, they tried the mother and father approach, information support, home visit, community work, everywhere the father was involved. And again, they found that early initiation of breastfeeding was 81% as compared to 40%. So there was a vast difference when the dad was involved. Exclusive breastfeeding at 4 months was 21% as compared to 11%. So what can fathers do? So many a times, fathers are left out of the entire situation, thinking that they don't have a major role to play, they are not lactating, they are not breastfeeding. But there are a lot of things that the fathers can do. First of all, fathers can gain knowledge about breastfeeding. They can try to understand its benefits, the correct techniques, and all things that would benefit in the long run. They can be fully present during breastfeeding. So suppose a mother is feeding, the father can try to be there with her, support her constantly, help her with different things. He can provide the emotional and mental support that the mom requires. Appreciate mom and her achievements, even if there is a small achievement, even if there is small improvement in her situation. So if suppose a mother is really struggling, and if he sees that yes, yesterday was kind of better than today, probably he can just keep on telling that to the mother that yes, we are doing good, we are on the right track, and we'll achieve the goals together. Know when not to help or give advice. So again, that is an important thing. So every time a mom might not be in a mental state or state of mind to just keep on getting advices, because she might not feel that a person who's not lactating or not breastfeeding would be able to understand what she's going through. So sometimes the partner should know when not to give those advice and when to just leave, give her that space, and let the mother be. Canadian researchers found that responsive support led to longer breastfeeding. So what is responsive support? Like when the dad gives that support when it is asked for, or when he sees the cues for those that the mother needs those supports and asking for them. How can fathers help with breastfeeding? He can listen, communicate, be the baby transporter, help to bring the baby, take the baby away, burping, साठी मदत करू शकतात. He can help in changing the diapers, cleaning the baby. So mother has to spend initial few, about a month, she's constantly, quite frequently feeding the baby. So a lot of her time goes in that. So husband can provide skin to skin contact for the baby, help the baby, put the baby to sleep, cuddle, spend time, bond with the baby. So if he massages the baby, bathes the baby, spends skin to skin time, snuggles, sings, dance, when the baby has that connection with the father, it might be really beneficial, because suppose unfortunately a mother is unwell for some reason, she cannot be with the baby for some time, the baby should feel safe and have that connection with somebody else, one or two people in the family, so that at that time the situation can be handled and dealt with. So he can also ensure that the mother is very comfortable. So she's provided with a lot of pillows and comfortable space. The room temperature is according to her comfort. Bring her food, water, whatever she requires, books, music, whatever that makes her breastfeeding session more comfortable and happy. Taking care of household chores, so different things, cooking, cleaning, grocery shopping, payments, bill payments, everything can be taken care of by the father or other family members. Help improve her oxytocin levels. So oxytocin, very important hormone. It is called as the love hormone, and it is very, very crucial that the mother has that optimal secretion of oxytocin in her body while she's breastfeeding. And certain relaxation techniques, back massage, neck massage, head massage, meditation, deep breathing exercises, those can actually help to increase oxytocin in her body, and the father can definitely help regarding that and be there with the mother when she's doing that. Taking care of any gadgets or nursing aids that she's using. So suppose she's using a breast pump, any pillows, nipple shields, pullers, supplemental nursing system. So father can take care of sterilizing those equipments, making sure that the parts are kept safe, drying them, bringing her to the mother, and helping her with those. Laugh wholeheartedly with her, read to her, and give her company during the long feeds, especially during night. When the mother is nursing, she would not like she might not be very happy seeing that the dad is sleeping and she's not getting rest at all. So he can just try to be with the mother in those situations. He can take care of the baby while the mother gets to rest. He can console a baby when he's irritable and cranky. He can support whatever decision that the mother takes. So if a mother is currently, breastfeeding, she's decided to exclusively breastfeed, or she's decided to supplement for any reason, if she's decided to express milk and pump her milk and then give it to the baby, then the dad, her partner should be um, knowing why she's taken that decision and should be supporting it with her with that. Handling visitors to ensure that she gets the privacy that she needs. Similarly, handling family members. So जर नवऱ्याला समजतंय की a particular family member कोणीतरी आहे घरी who is negatively sort of demotivating the mother, काहीतरी wrong advice देतायत, he's passing on some myths, then he is the person who can actually talk to them politely, tell them, explain it to them properly. A mom might not be very comfortable talking to the in-laws, so he can actually bridge the gap, and he can give them the correct information. He can accompany her to all her visits, gynec, pediatrician, जर तिला breastfeeding ची help लागत असेल motherला, so she can book an appointment with a lactation consultant if she is undergoing any postpartum mood disorders or postnatal depression. He can go with her to a psychologist, just accompany her everywhere and remind her to take her meds, remind her to eat, keep herself hydrated, drink. So lots of things that the father can do. Similarly, family has a big role to play. So families should be motivators. They should also get educated. The family, extended family, they should also be educated about breastfeeding and get rid of their own myths and misconceptions, the myths that we just now heard ma'am speak about. So there are so many misconceptions with regards to breastfeeding. So it is very important that everybody is educated in the family, and they can attend antenatal classes along with the mother, so that so many things clear up. Talk to the mom about what her breastfeeding goals are and respect her decision. They can encourage the mom. Talk about her achievements rather than failure. Talk about what the good things are, bright side of the story. They can just talk about that. Give her support system.
Hello. Hello, Rashmi ma'am. Hello. Hello, Rashmi ma'am. Hello. Rashmi ma'am, we are unable to hear you. I guess the video has stopped. Hello. Participants, just give us a moment. Participants, just hang on. We are trying to connect with madam. Till madam. till Madam connects us.
Hello students. I'll be sharing with you the results of the poster competition by the time Madam joins back.
चहा काय तू चहा देत नाही मी आज तुला चहा पिला गरीब चहा देऊ नको हिला आता
I'm not able to share my screen.
Just try, ma'am.
Yeah, I'm so sorry for the interruption. Yeah. Yeah, so family has a big role to play. They can be with the mother, attend antenatal sessions with her. They can talk to the mother about her breastfeeding goals and respect whatever decision that she takes. Encourage her, talk about her achievements rather than her failures. Talk about whatever good things are happening. Help her with the housework, take care of the older kids if they are there. Make the environment soothing and relaxing for the mother. Society as a whole, it is said that it takes a village to raise a baby. So similarly for the breastfeeding support also, there are many people who can actually support and who play a role. Peer support, very important. Mothers like and benefit a lot from listening to other moms who have had similar experiences, and that makes a lot of difference when they understand what they experienced and how they dealt with their problems. So there's a Facebook group, Breastfeeding Support for Indian Mothers, BSIM, which has lakhs of mothers, and I've seen how much support these new moms get there from experienced moms, and they can share whatever doubts and queries that they have, and people respond to that, and their specialists and professionals and moderators who respond to them, and they indeed get a lot of support there. Then there are different WhatsApp groups for new moms. There can be mother support groups at the individual basis. Different hospitals can have different groups, so they play a very important role. Friends definitely play a very important role. They can be there with the new mother. They can listen to her patiently, tell her the positive stories and advice when they are asked for it. Colleagues at work, once a mother resumes her job, they can help to share her workload, maybe, give her some breaks so that she can express milk or feed the baby. And they can, just help her with the work in that situation. The health providers, again, we have healthcare providers have a very big role to play. So we can make facilities for antenatal counselings, the gynecologists, pediatricians, nursing staff, nutritionists, physiotherapists, everybody who's involved, who come in contact with the expecting moms and lactating mothers should themselves get formal training and education and have appropriate knowledge about breastfeeding and lactation. Hospitals, they should should have a strong breastfeeding policy, and everybody should follow that policy. So there should be strong breastfeeding policy at every level. Medical professionals should adhere to IMS Act. So what is an IMS Act? It is a law basically in India which says ki, medical professionals should not associate with companies who manufacture infant formula, because then that causes a conflict of interest. So we should not be taking any perks or any sponsorship by such companies. Lactation consultants should be made an integral part of the medical team. So 13 years back when I started, people were not aware, people were questioning, like why lactation consultants are required and what is their role. But now there's more and more awareness, more people are interested in this field, and we do get that respect, and people look forward to what we decide for the patient and what are our views and opinions on that. uh, um, there should be more facilities of breastfeeding clinics, follow-up clinics for breastfeeding moms, where they can come and take help regarding breastfeeding. More lactation helplines should be there to help these mothers. We can create more educational aids like posters, blogs, web pages to educate and inform these mothers. Suppose you are an employer, or anybody is an employer who owns a company, and a lot of people are working there, including a lot of mothers, new moms, lactating moms, then we should try and make provision for a paid maternity leave. Definitely, you can give them facility of flexible timings where a mother can choose what time to what time she can be there. Work from home facility, provision for part-time work initially, maybe. They can have lactation consultants on their panel who can guide these breastfeeding moms, from time to time. Provide clean, hygienic private room for breastfeeding, milk expression. They can provide electric breast pumps or milk storage facility for these mothers. It would be a boon if they have creche or a daycare facility in the campus of that company, and create a supportive environment for these lactating moms. Last but not the least, we need to normalize breastfeeding in public. Baby needs to eat when he needs to eat. He needs to eat, drink when he's hungry. And suppose a mother is out anywhere, she should be absolutely comfortable and not embarrassed, or uncomfortable feeding outside. So be it in parks, be it in transport, be it in movie halls, malls, mother should be easily able to breastfeed there without somebody, staring at her or passing any negative comment on her. So we need to create that conducive and a very comfortable environment for mothers, even outside work. The baby should not starve in any case, and mother should not wait for her to reach home to breastfeed her baby. Celebrities and influencers play a major role. So celebrities should always give positive messages, especially mothers who have had first-hand experiences. I put pictures of Sohali Khan and Samira Reddy. We know that they are followed by a lot of mothers, and they have set a very high standard and example. Samira Reddy has shared her experience of facing postpartum depression, and many moms could relate to her. So these celebrities should also take care that they are not giving any negative examples. So suppose a mother sees a celebrity breastfeeding, there are many lay people who follow them and who might not understand what precautions they are taking. Obviously, bottle feeding is an individual decision, and if a mom chooses to do that, that's fine. But when you are a celebrity, you have more responsibility. So they should be aware that they are not giving wrong examples. People might not be aware what negative what disadvantages bottle has, or how it can have a negative impact on the health of the babies. So they should be careful about that as well. This part of my session, I would just like to end with a quote, which I really like. So by enabling women to breastfeed, we address women's rights. Since the improvement of women's social and economic status is necessary for supporting breastfeeding, any violation of women's right to breastfeed is a violation of women's human rights. Moving on to the next part is concept of human milk banking. So I would just do that in brief. So we know that WHO recommends 6 months of exclusive breastfeeding and continued breastfeeding at least till 2 years. WHO also recommends that where a baby is unable to receive the biological mother's milk, his own mother's milk, milk of another mother is the next best. So in order to ensure that there's safe supply of breast milk for all infants, regulated milk banking is the safest means of doing that. A little history about milk banking. So wet nursing was quite prevalent in the 1800 BC. There was a widespread of syphilis in the 15th century, after which the rates of wet nursing went down. Milk sharing and cross nursing is still practiced, but it is not recommended. The first human milk bank in the world opened in Vienna, Austria in 1909. At present, there are more than 750 milk banks in 66 countries in the world. The first human milk bank in India it started at 1989, and in India there are around 85 human milk banks currently. More than 8 lakh infants receive donor milk every year. Over 1 million liters of milk is being donated annually.
कोंबडे 5-8 झाले माझ्या ह्याच्यात. हा मग तरी पण 5-20 करू का? 5-8 म्हणजे किती मिनिटाचं करायचंय? 25 मिनिटं.
Am I audible?
Yes, madam, you're audible.
Yeah, okay. So this is a picture of the human milk bank that was first human milk bank in India, which was established in 1989 by Dr. Armida Fernandez in Lokmanya Tilak Municipal Medical College and General Hospital, Mumbai, which is popularly known as Sion Hospital. Coming to definition of human milk banking, a human milk bank is a service established for collecting, screening, processing, storing, and distributing donated human milk by prescription. Collecting, screening, processing, storing, and distributing. What are the common challenges that we usually face while setting up a human milk bank? So there can be lack of awareness. खूप लोकांना अजूनही माहिती नाहीये की human milk bank काय असतं. What all is required for setting up a milk bank, whether it will work, whether it will not work. So if you are thinking of starting it in in a sort of hospital setup, the administrative approval may take time. So it took a long time for us to convince the hospital that it is the need of an hour. Concerns of donors and recipients, they can have certain concerns. Then milk bank infrastructure, खूप जास्त infrastructure लागतं त्यासाठी. There's funding and cost involved to start the milk bank. So all the equipments, infrastructure. At the same time, you require funds to keep the milk bank operational. There are costs that are required throughout, for the functioning of the milk bank. Staffing, highly trained professionals are required for that, and we need to maintain really high standard protocol, just like they are maintained in a blood bank. So what is the need? Milk bank chi garaz kaya hai? Every year, 27 million babies are born. 7.5 million, that is 30% of those are low birth weight. 3.5 million, 40% of these are around preterm. 0.75 million infants who die in the neonatal period prematurely. Prematurity is the major cause. About 75% of premature infants can be saved with feasible and cost-effective intervention. Breastfeeding is the single most powerful intervention we know. It has a potential to prevent 0.16 million under 5 deaths in India. Human milk is both immunological and nutritionally ideal. And many studies have shown that, especially for vulnerable infants, small, preterm, extremely low birth weight infants, there's reduced risk of sepsis, reduced risk of NEC, necrotizing enterocolitis, length of stay in the NICU, better feeding tolerance, and substantial cost savings when they are given PDHM and not given formula milk. The donors can have various concerns. So a mother might be doubtful ki malas milk vyavasthit yete ki nahi, whether if I donate my milk, whether I'll be compromising my own baby's health. So that doubt can be there in a mother who's a candidate for donation. Parents of the recipient baby may fear ki hatun kai dusra disease ki virus tapas nahi honar baby la. There can be concern about the nutritional value ki kharas खूप चांगलं आहे की नाही आहे, and there can be certain personal beliefs wherein people would not want their baby to be given other mother's milk. So what can be done in such cases? So you need to reassure patients. Lami sangto ki, lot of strict protocols and screening protocols, serological testing, everything is done. Till date, there has never been a single reported case of disease transmission through the use of pasteurized donor breast milk. The possible risk must be weighed against the proven benefits, obviously, in each case. So individual upon decision घ्यायला पाहिजे प्रत्येक patient साठी. Boosting of mother's confidence, you need to boost that she can definitely produce enough milk for her baby. She can also produce excess milk which she can donate. Increasing awareness through social media and other educational aids is very important. What infrastructure is required? So mostly the prime candidates for PDHM pasteurized donor milk are the preterm babies or babies that are admitted in the neonatal intensive care unit. So it is preferable that the milk bank is within the premises of the NICU. The minimum requirement is that there should be a partition room of 250 square feet. The one that we have at KM is around 400 square feet. A work area for the technician, as well as some storage space for records, administration, and area for counseling of donors. These are just pictures of our milk bank. So we have a small sort of room for mothers to sit and pump. There's another feeding room in the NICU, but this is within the milk bank. And there are breast pumps available there. This is an area where me and my colleague, we counsel the patients and we do all the record keeping of whatever goes. And there's a working area where the entire process, pasteurization and everything takes place. So what are the major equipments that are required? We require an air-conditioned room. We require a pasteurizer, deep freezers, preferably 2 deep freezers, which are minus 20 degrees Celsius, one for raw milk, which is donated milk, and one for pasteurized milk. Then refrigerators, thawing equipment are an option. You can have orbital shakers, homogenizers. You can do without them as well. Breast pumps, if you have hospital grade breast pumps, then better, because that will really help the mother express with much more convenience and in a faster manner. And an uninterrupted power supply. So if there are a lot of power supply issues, then probably a generator backup is a must. So these are the equipments. Basically, this is a deep freezer, sort of minus 20 degree deep freezer. So this is where we keep our raw milk, the donated milk. This is our pasteurizer. So there are different pasteurizers. Ours is a new indigenous pasteurizer called Kimi. The capacity is 500 ml. So it is the capacity is quite less, but आमच्या unitला setup light is quite fine, because आमच्या NICU मध्ये maximum mothers are actually giving their own milk. So hardly 1 or 2 baby every day is requiring pasteurized donor human milk. And this is a room air sterilizer, a refrigerator. Here is where we thaw the milk. So freezed milk is brought to room temperature by very sort of gentle heating. And this is a deep freezer where the final pasteurized and the milk for which we have gotten the reports, the bacteriological reports have come and they are sterile. They are kept and it is ready for dispensing. So it is ready to give to the babies that are admitted in the NICU, the NICU babies, for whom their own mother's milk is not available for some reason. So all milk banks basically work on triple protection manner. So what is triple protection basically? कि पहिले आम्ही donor ची history घेतो, thorough history is taken. We ensure that she doesn't have sort of diseases which can pass on from the milk, and then if her serological testing is not done, we do have reports, because we are collecting right now currently from whoever are our patients, inpatients we collect it from. But if that is not available, then those testings are done. Then the milk is pasteurized, and after pasteurization, again we send the bacteriological cultures to ensure that the milk is completely contamination and bacteria free. So most milk banks follow the guidelines of Human Milk Banking Association of North America, HMBANA. For testing, we see that the mother doesn't have HIV 1 and 2, HTLV 1 and 2, hepatitis B and C, and syphilis. So donor mother should be free from these. Informed consent, very important part. So mother who's a donor should be doing it willingly, and she should not be forced to donate. And we should, or the doctor should ensure that she is producing enough and providing it to her baby first, and then donating whatever is excess. Written parental consent must be obtained before prescribing or administering human donor milk. So recipient consent also needs to be taken. So both donor mother and the parents of the recipient baby should give a consent, and all the perceived benefits, precautions, and potential risks should be explained to them. How is collection done? So donors are educated about the most hygienic way to express. If she's using a breast pump, how to sterilize them, how to hand express, how to use the breast pump properly so that it doesn't cause any nipple injury. Drip milk or the milk that leaks is usually low in caloric value, so and susceptible to contamination. So we avoid taking that milk. Collecting both foremilk and hind milk is important. सुरुवातीला जे milk येतं आणि जे नंतर येतं, both milk needs to be collected. In an Indian scenario, even IAP recommends ki home collection, we should try to avoid them, because we don't know how the donor has expressed, where she has stored, whether she's followed everything. There's risk of a lot of electricity failures, so that there can be temperature fluctuation when she's storing. So we cannot be very sure about that. Where your own setup doesn't have much donation, then we are not left with much of an option but to collect it from home. So in that case, milk van which is installed with breast pump and a cool box could help. So this is how the milk is stored. So what is pasteurization? Basically, we use Holder pasteurization method. Most milk banks would use that only. The milk is heated to 62.5 degrees Celsius, and that temperature is maintained for 30 minutes, and then suddenly that milk is cooled. So from 62.5 to 25 within a period of 10 minutes. So sudden cooling of that milk is done. So why this is done? Because at 56 degrees, most bacteria and viruses are adequately dealt with while retaining many of the immunological and nutritional properties of the breast milk. Any milk that is culture positive for any pathogen, raw milk, which is greater than 10⁴ colony forming units, and skin flora before pasteurization, or any positive culture post-pasteurization. So we don't send pre-pasteurization cultures, but post-pasteurization, if the bacterial, there is any bacterial count, that needs to be discarded. What is pooling of milk? That is, we collect milk from 3 to 4 or maybe 6 donors and pool it together before pasteurization. So few units do it, few units don't do it. But if you do it, there's a benefit that the values of nutrients in different mothers might be different, you know, the protein content, the carbohydrate content. So when you pool the immunological and nutritional content, it averages out. Okay, and the number is kept low so that we can trace it back. So 4 mothers आपण घेतलंय, and suppose for any reason it comes, the culture comes positive, आपल्याला कळलं पाहिजे की हे कुठल्या मदरने डोनेट केले. So we should be able to trace that. Storage: fresh raw milk is stored at 4 degrees Celsius and no longer than 72 hours following milk expression. Frozen milk can be stored at -20 degrees Celsius for 6 months. So ideally 6 months till 12 months it is acceptable. Usually polycarbonates, Pyrex or propylene containers are used for storing. Polythene bags are fragile and associated with a loss of IgA, loss of vitamins and lipids, and there's risk of contamination. The bags can get punctured, so it is avoided. In Indian setup, even stainless steel containers with tight fitting screws can be used. They are easily available, durable, easy to clean and autoclave. So general guidelines for the staff of HMB, that standard operating procedures, SOP of the bank should be attended to. Hygiene practices like proper hand washing, gowns, masks, gloves, trimming nails, locking long hair should be maintained. Gloves should be worn and changed between handling of raw and heat treated milk, that is pasteurized milk. And there should be a program for ongoing training of the staff. Again, I come to the end of my session, my lecture. Very happy World Breastfeeding Week to all. I'm just ending it with a few pictures of celebration at KEM Hospital. So we had a cooking competition for the staff where they were told to make a nutritious recipe for mothers, which were enriched with galactogogues, you know, for lactating mothers. Here we had a sort of interactive session for the mothers. They did a role play 3 to 4 role plays were done telling about the benefits, where we also got to see the counseling skills, because counseling skills play a very important role. So these are just few glimpses of how we celebrated it. Thank you so much. So let's work together and let's make every day a Mother's Day. Thanks a lot.
Thank you, Rashmi ma'am. It was a really informative session. You explained thoroughly about what situations and COVID situation, how the mother went with the loss of support system, which is very important for the mother's psychological health. He also very well described about the responsive support the father needs to give a mother whenever it is needed, not all the time, just lot many informations to be given to the mother. You discussed the human milk bank very well. We came to know many points from it. Thank you very much, ma'am.
Thank you so much. It was an honor to be here today. Thank you. Thanks a lot.
Thank you, ma'am. With this, now we'll move on to the moment that everyone is waiting for. May I call upon Ms. Amarja Gosavi ma'am to announce the results of online poster competition and quiz competition. Okay. To begin with, the winners for the poster competition are Ms. Vaishali Sudha Mari from Pune, BTINE. The second prize goes to Ms. Akshata Rajesh Varvar from BTINE Pune. And the third prize goes to Krishna Vithoba Bopare from Dr. Hedgewar College of Nursing, Aurangabad. There's a consolation prize to Ms. Nehal Wagmare from RJS Con, Kopargaon. The second competition which we had conducted was quiz competition. So there are for the first place, there are two winners, that is Ms. Gauri Pawar and Mr. Huzaif Sheikh from third year BSc Nursing, and the second one goes to Ms. Asmita Deshmukh. Congratulations to all the winners. Hope to see you soon in other competitions also. Now we'll move on to our feedback sessions. May I now request few participants from today's webinar to give feedback. May I call upon Mr. Noel David, who is an MSc Nursing student from Dr. D.Y. Patil College of Nursing, Kolhapur.
Good evening, ma'am, and good evening, everyone. I hope I am audible.
Yes.
Yeah, thank you.
Can you put on your video, please, Noel?
Yes, ma'am.
Can you put on your video?
Just a second. Yes, ma'am. Really moving toward the feedback session. We know a communication process always completes with a feedback, right? And going towards the feedback about this communication and all this webinar. So I really thank Mother Teresa College of Nursing, Aurangabad, for attending such a good webinar about World Breastfeeding Week. And the theme for this year was about protect breastfeeding, a shared responsibility. And I really thank the college for attending such a well webinar, and with the new terminologies we were introduced. And I also thank Dr. Joshi ma'am for introducing with the basics of breastfeeding and giving us a very good demonstration about how breastfeeding initiates and all those things Joshi ma'am has explained. I thank to them. It really gave a boost up, and it really encouraged our awareness for having this breastfeeding. And later on, Mrs. Rashmi ma'am, who told us about all the breastfeeding support and human milk banking. And breastfeeding is not only about mother and child, but breastfeeding is about family that involves mother, child, and father. And for giving us that information, I would also like to thank them. And one of the thing which I especially came to know, or I came to know about this webinar, that is breastfeeding is a blessing to our children. One of the sentence that ma'am spoke, that breastfeeding is a vaccine, but I would also like to add in that breastfeeding is not only a vaccine, but breastfeeding is a blessing to our children that helps him to grow and develop in his further life. That was my feedback. Thank you very much.
Thank you, Noel. Thank you very much. Moving on to our second feedback by Ms. Kritika Tidke. She's a clinical instructor at Sushruta Institute of Nursing Science, Daud.
Thank you, ma'am. Actually, congratulations that you did very well. Miss webinar is very good and session is very well done. And Neha Joshi ma'am nicely demonstrate breastfeeding techniques, and she did very nice session. And then Podwal madam gives a very good knowledge and informative and she did very informative session. And also म्हणजे आज आम्हाला कळलं about the today we know about the human milk bank, and that is very nice. Okay. Thank you, ma'am. Thank you, ma'am.
Thank you, Tidke madam. Thank you very much. Participants, kindly note the link for the feedback has been posted in the chat section. So kindly fill in the feedback form. As we come to the end of this webinar, I now call upon Ms. Akanksha Ghorpade, faculty, MGM Mother Teresa College of Nursing, to give vote of thanks.
Very good evening to all of you. Hi, Ms. Akanksha Ghorpade, faculty, MGM College of Nursing. To commence with, I would like to give glory to the Almighty God for making this webinar a resounding success. Foremost, I would like to thank Dr. Anuradha Maske, Director of MGM Mother Teresa College of Nursing, Dr. Satish Chandra Boite, Principal of Mother Teresa College of Nursing, Madam Prerna Darvi, Deputy Registrar and Administrative Officer, a Vice Principal, Dr. Vishwanath Biradar, for extending your valuable guidance with us. I'm so very grateful to all our today's speaker, Dr. Madhuri Engade, HOD, Department of Pediatrics, Ms. Neha Mihir Joshi, Lactation Consultant, and Ms. Rashmi Podwal, Lactation Consultant and in charge of Nectar Human Milk Bank, who in spite of the busy schedule, accepted our invitation on a very short notice. Thank you so much for enlightening us with your highly informative words. I owe my special gratitude to our lecturers, Mrs. Prabhadevi N. Ma'am, Ms. Amarja Gosavi, Ms. Merlin Shinde Madam for taking a joint initiative in organizing this breastfeeding week in MGM Mother Teresa College of Nursing. I thank all the faculty members of Department of Obstetric and Gynecology, Department of Child Health Nursing, Community Health Nursing departments, and all the other teachings and non-teaching faculty, as well as the technical supporting members. I also express my heartfelt gratitude to all the participants and students from all over the Maharashtra who have enthusiastically participated in poster competition, skit demonstration, and quiz competitions. Thank you so much for making this event a great success. Once again, I thank you all for your kind attention.
A takeaway message for today's webinar for the breastfeeding mothers would be, just keep in mind that it will get easier every day and you will soon forget those hard days. Not only you are bonding with your little one, you get to save a ton of money in the process. Remember, both of you and your baby are learning this whole breastfeeding thing, and it takes time, but it is so worth it. Thank you, participants, once again. We will be soon sharing the link of the posters. Okay, it is already shared in the chat box. You all can go for the post test and the feedback. Certificates will be issued accordingly. Thank you, participants.